For our listeners, maybe I'll just say a little bit about what 340B is, right? So it's a program that was created in 1992, requiring drug manufacturers to sell drugs at a discount to hospitals who are providing care to low income or uninsured patients. That's really the goal of it, to improve access to these drugs for people who otherwise wouldn't be able to afford it. And so hospitals can use this money to fund other programs. And it's a very profitable program for hospitals. So they also look to acquire other hospitals that give them access to this program. So let's say if you're a hospital in a county that's otherwise wealthy, that you would not qualify for 340B, it it encourages expansion into those communities that allow for 340B, so they can get these profits and potentially, instead of just using them on underserved care, use it to fund other programs they're running. And around reform, there's not much regulatory oversight. So there's this concept of HRSA, which is the Health Resources and Services Administration under the HHS, which we'll talk about a lot in the episode. But the statutory authority of theirs is very thin. It's 3 pages of law. And so there's really as you said, hospitals can spend this money in whatever way they want. The original intent was hospitals could only dispense these 340B drugs on site. But in 2010, HRSA allowed this concept of contract pharmacies, which are retailer specialty pharmacies that dispense the 340B drugs on behalf of the hospitals. And one of the other aspects about the program is there's a lot of reforms that are currently being done. Some are revolving around rebates that we'll get into. Some are on the state level that we'll get into. Some are around increased transparencies and ways to improve the transparency. Because, the next few years will really test whether Congress or the administration can modernize 340B without destabilizing the hospital finances and still preserving that community oncology access.